meetings and academic capital of India as well. Because of the three reasons, I'm very happy, and I really remember my days in GCRI, where we used to know each other and start a long-standing friendship and career. So coming to the gastric cancers in India, this is an important disease. This is an editorial which is written by us in me as well as our two international writers in Indian Journal of Surgical Oncology. So the highlight was the alarming rise of stomach cancer in India, and the outcome of stomach cancer is little bad all over the world. If you look into this particular publication by Lancet, which looked into the publication of Concord 3 trial, which looked into the pattern of care across the globe, you can see that the survival is 35.9 in China, USA is 33, and Japan is having 60. All are 5-year survivals. And one thing which is happening is over the 20 years, the 5-year survival is increased by 6 to 10% in Canada, Israel, and Japan, Estonia, and 11% in USA and Germany, and 20% or more in China and Korea. So as Indian, we are curious, what's survival in India? It is dismal. It is 8.9%. So I think something is lacking in India. Should be the standardization of surgical practices and other modalities. But at the same time, if you look into the survival in institutes like our institute or the institute we work, it is okay. But in Pan India, it's still not very acceptable. So it is our duty to make sure that the training we received is percolated to each nook and corner of the country, and our surgeons start performing better surgeries. Again, if you look into the pattern of relapse, you can see that this is the results of a Japanese AC-HCT GC randomized trial. But when you look into the AC such trials in Japan, these are the recurrences which is happening after the best management of the lymph node as well as the primary. Again, the lymph node recurrence is high compared to local recurrence. If you think about where as a country or place where the disease is not adequately surgically managed, you see a lot of distant metastasis as well as local recurrences as well. So in this discussion, I am targeting mainly a surgical audience, and I'll be speaking about some tips of stomach cancer surgery, the way we practice in 2021. Unfortunately, the year known as the year of the COVID. But even then, we shouldn't forget cancer, and we have to see the developments which are happening in cancer. And the two issues I like to discuss in surgically are only two. One is when to do surgery and how to do surgery. Coming to the surgical aspects, please remember that the diagnostic laparoscopy is a procedure which is recommended by most of the guidelines. And it is very important to do the diagnostic laparoscopy when you suspect a stomach cancer which is more than T1A or which is less than stage T4. So only in T1A and in T1 stage 4, you need not do a diagnostic laparoscopy. So where do you want to do a diagnostic laparoscopy? The almost 50% of the metastasis which comes in the peritoneum are even missed by CT scan and as well as the PET scan. So the diagnostic laparoscopy should start with a diagnostic peritoneal lavage. Again, once the diagnostic peritoneal lavage is positive for malignant cells, this issues raises a lot of questions, confusion rather than solution. So how this patient should be managed? So shall we abandon the curative attempt and palliate the patient, or shall we try some chemotherapy and do operation later on, or shall we do straight away go to HIPEC? These are the main various issues you faced by the positive diagnostic lavage, and many countries and many hospitals have their own pathways and protocols which are unfortunately different. So why do I need to do a diagnostic laparoscopy? Number one, the tumor, which is the nodule, which is less than 5 mm, are going to be missed. And we have analyzed, we started doing a diagnostic laparoscopy for all cases as a study protocol. And we have found out that nearly 40% of the METs, which is not detected by CT scan, are getting detected by the diagnostic laparoscopy. And that itself avoid unnecessary chemotherapy for the patient who otherwise would have been having a very simple palliation. Again, you should also understand one more investigation is needed in other than CT scan, which is endoscopic ultrasound. In the modern management of stomach cancer at 2021, the endoscopic ultrasound is very important to know the T staging. Not only the T staging, a node which is more than less than 8 mm is picked up by the US. So actually, it increases the sensitivity and specificity of T staging as well as N staging. So both NCCN and ESMO recommends US for better staging of stomach cancer unless it is very advanced or very early. So what is the resectability? It is easier to say what is unresectability. Unresectability means a distant metastasis, a nodal medicine, mediastinum and para-aortic, repro, infrapancreatic area and portohepatis, an infiltration of hepatic artery and celiac axis and proximal splenic artery. I'm sure that these are the guidelines, what the guidelines recommend, but in practice, I think in selected places where you have isolated local metastasis, with the help decision by the MDT, there is no harm in going ahead with the resections if possible. Again, adjacent organ resection is a very common practice. Colon and spleen are often resected, and involvement of these organs are not at all a contraindication, because after resection of these structures, you have a survival of which is more than 30 to 40%. But Whipple's by and large is not advised as a part of combined organ resection, except in unusual situations. So we should all understand that now the stomach cancer, which is more than stage 1A and which is less than stage 4, has to go through some adjuvant protocols. And I am not going to in detail about adjuvant protocols. But again, coming to the stage 4 cancer, the surgery is again needed for palliation. It can be either resection or bypass for obstruction and resection for bleeding. And when you think about the palliation of gastric outlet obstruction, even now all the guidelines are recommending surgical palliation, not stents. Linitis plastica is a unique condition where the entire stomach wall is infiltrated and it is very thickened and non-distensible. And please understand, especially the trainees, please understand, this is not a surgically treatable condition. The patient has to go for a neoadjuvant protocols, and very few patients having linitis plastica will get the advantage of the resection. So don't do surgery at the first. Actually, the MD Anderson Hospital protocol, which is published up to date, they said linitis plastica has to be treated with chemotherapy for 6 months, then do chemoradiotherapy, and then only surgery if still resectable. So linitis plastica, there is no straightforward surgery. Again, adjuvant, if you think about adjuvant, the most important trial was IND 0116 trial, which is so much criticized for inadequacy of proper lymphadenectomy. Unfortunately, there is a practice in US and many Western countries. And but Asian countries are going ahead with a very perfect lymphadenectomy. I'll come to that later. Slowly, the adjuvant is replaced by new adjuvant protocol. We started with MAGIC and later on by FLOAT, which both trials showed the overall survival advantage, and that becomes the standard of care for any tumor which is T2 or more or N+. So these are the simple algorithm for diagnosing a gastric cancer. When a patient presents in a resectable stage with obstruction or bleeding, you should go straight away with the surgery to palliate as well as cure. Don't think that the straight away surgery should be always palliative. So whenever possible, try to do a good resection also, because many of these obstructive patients can be cured. And when there is no complication, we have all the time to decide on the T-staging by means of the laparoscopy as well as TUS to know whether it's T1 or more. If it is T1 N0, again go with the straightforward surgery. And if it is T2 or more, we have to rely on NAC, which is described already. So the issues with surgery, which I'm going to discuss, is what is the extent of resection, and what is the extent of lymphadenectomy, and what are the margin recommendations, and what are the present status of the so-called rituals like bursectomy and things like that. Again, if you compare the total versus partial gastrectomy for distal stomach cancer, there is no need to do a total gastrectomy always. Even a good subtotal gastrectomy with the clearance of lymph node is good. Not only it have better perioperative outcomes or equal perioperative outcomes and oncologic outcomes with compared to total gastrectomy, it has a better QOL postoperatively, including the nutritional consequences. These have been proved by two very important trials. Coming to the margin and notes, again, we did a very interesting study in RCC last year. We looked into the how the patients who had undergone various surgical procedures for a proximal gastric, especially the OG junction tumors behave. And we had various procedures like McKeown, Ivor-Lewis, THE, proximal gastrectomy for this proximal gastric tumors, OG junction tumors. And we have found out that the number of positive margins were much poor when we attempted the proximal gastrectomy, where we didn't remove the esophagus. And so the 5-year survival is dismally low in this subset of patients compared to the patients who had undergone a McKeown with a longer margins. So this study reiterate the fact that a proper margin is important. If you think about the margin, the proximal margin should be based upon the type of the tumor. If it is diffused, it is poorly differentiated, a 5-centimeter margin is recommended. So that often involve the resection of the significant length of esophagus also. If it is a well-differentiated carcinoma, you can get away with a smaller margin, which is as small as 2 to 3 centimeters. So this is the dictum everywhere in stomach. If it is a intestinal tuft cancer, you can get away with smaller margins. But other than OG junction, generally 5 to 6 centimeter margin is recommended. Again, for the proximal versus the total gastrectomy, the issues are the unattended lymph nodes. And this particular study showed that the survival is same, but at the same time, the local regional recurrence was a little high with the proximal gastrectomy. So proximal gastrectomy has to be viewed with little suspicion. So coming to the most important aspect of stomach cancer management is lymph node stations. So a lymphatic pathway is very important. Once the disease goes beyond the T1 stage, T1A stage into submucosa, the lymphatic pathways are activated, and even with a T1B tumor, the risk of lymph node metastasis is something like 5 to 10%. So the spread luminally is different. In esophagus, it's spread by a submucosal spread, which is very common. But the distally it's spread to the duodenum by the subserosal spread, which is not so common. If you look into the lymphatic axis of stomach, there are 4 types of drainage pathways, where the upper middle part of the stomach reaches the left inferior phrenic artery and to the left subdiaphragmatic pedicle. The upper and lower part of stomach, in the mid stomach as well as the entire stomach, goes mainly by a celiac pedicle through the lymph nodes along the left gastric, splenic, and common hepatic arteries. And lower portion of stomach goes to the superior mesenteric pedicle through the infrapyloric nodes and root of the superior mesenteric artery. And lymph flow from the lower portion of the stomach reaches the retropancreatic pedicle through the lymphatic from retropyloric nodes. So this principle has to be remembered when you attempt a surgical resection and lymphadenectomy of tumors located in various affects various locations of the stomach. Again, if you to avoid confusion, if you classify the lymphatics from upper half and lower half, the upper half of stomach spread to different vessels along the left gastric artery, posterior gastric artery, splenic artery, and left inferior splenic artery without lymphatic connection with the retropancreatic or mesenteric nodes, station 13 or 14. At the same time, lower half of stomach lymphatics channels along the common hepatic artery and superior mesenteric artery, draining to station 12 and 13. So there are 33 regional lymphatic stations. The Japanese has classified it into 3, N1, N2, and N3. So the station 1 are usually station 1 to 6, with the various subdivisions, which are mainly perigastric nodes. And station 2 nodes are 7 to 12A. And the most important nodes which have to be removed in all are usually the station 7, station 8A, and station 9, and station 11P. So this is the proximal stomach where you need to remove the paraesophageal nodes as well. Again, if you look into the development of lymph node surgery in the West, you can see that it started in 1993 in Germany, where the initial publication about the radical dissection, which involved more than 26 nodes. So before I forget, I'll tell something about the number of nodes and the survival. So number of nodes dissected is connected to the survival. The 1997, they have looked in a SEER database has analyzed, and they have looked into the survival and number of lymph nodes, and they have found out that minimum 10 lymph nodes have to be removed to get some significant impact on survival. And after that, every 10 lymph nodes resected more, up to 40 lymph nodes increases survival. So this is very important. And how many nodes have to be removed in gastrectomy? It is 16, according to the NCCN. 16 nodes has to be removed, then only we can properly stage it and treat it. You all know that a lot of trials have been conducted in Western world, and with a very sad and very negative effect. None of them showed that increase in survival. So when you look into this, you can find out that there are a lot of flaws with these trials. Not only the way these trials are conducted, but increased morbidity and mortality even with the D1. So if you look into the MRC trial, you can find out that 13 patients who had undergone a D2 lymphadenectomy died, and even D1 arm 6.5 is a huge number. 1 out of 20 patients dying is so unheard of in most of our hospitals where we do D2 lymphadenectomy right and left. So because of increased mortality of both arms, especially with the D2 arm, all these results are failed. So why these results are failed? A lot of reasons: the inadequacy lymphadenectomy, obesity, and a lot of issues. And one thing which is pointed again and again is unnecessary removal of pancreas and spleen. But I don't think beyond that, there are a lot of other aspects also involved in the failure of these trials, which didn't show any increase in survival with D2. Again, if you look into Western trials, you can find out that poor quality control, non-compliance. If you look into Dutch trial, the non-compliance was 51%, and in MRC trial, station 7 was dissected in 63.5% only. Similarly, station 8 and 9 dissected only less than 50%. All this contributed to the ill fame of D2 lymphadenectomy in Western world. So again, if you carefully analyze these trials, again, Dutch trial was also saying, even after getting trained by Japanese surgeon and operating almost same, but the long-term results show that there is in D2 arm, especially patients who are having posterior lymph nodes, there is gastric cancer death has been reduced significantly. So this is one tiny minuscule hope which is seen in the Western trials. But if you look at Japan, people are so convinced, and if you doing a D1 versus D2 lymphadenectomy is highly unethical in Japan as well as in many Asian countries. And in our centers also, we routinely perform D2 lymphadenectomy. So the indication for a D2 lymphadenectomy should be N plus or CT2 or more, and a D1 or D1 plus can be done in CT1 N0. And why can't we do lesser invasive, lesser resection like wedge excision, etc.? So only when there is no chance of lymphatic spread, you can go ahead with this kind of resections, including wedge resection or EMR, only for T1A disease. So Japanese surgery, according to the guidelines, which is published in 2020, the curative surgery is a standard gastrectomy where at least 2/3 of the stomach with D2 dissection is mandatory. They have removed the inclusion of the splenectomy or splenic hilar dissection from the D2. So it is needed, it is need to be removed only when it is indicated. And a non-standard gastrectomy is either it is more radical or less radical than the standard gastrectomy. A modified surgery, for example, the extent is reduced. Instead of D2, you are doing D1 plus, this is non-standard. Or you are resecting the adjacent organ also, it's called extended surgery is also non-standard. Any lymph node beyond D2 is removed. You are doing a D3 lymphadenectomy, it's also called non-standard gastrectomy. So in total gastrectomy, these are the stations which is usually removed. In D0 is less than D1 is called D0, and D1 1 to 7 is removed. Mind you, in the Western classification, up to 6 are considered D1. In Japanese classification, even 7, level 7 is also considered D1. And in D1 plus, in addition to that, you remove 8A, 9, and 11P. That is hepatic artery node, anterior node, and the celiac axis node, as well as the proximal splenic artery node. In D2, in addition to this, you remove 11D and 12A, which is hepatoduodenal ligament nodes, as well as the distal splenic artery node. Coming to distal gastrectomy, it's similar but slightly different. In D1 plus, there is 11P need not be removed. You need to remove. You might be remembering the lymphatic pathway described earlier. The distal pathways mainly go via the downstream pathways. No, it won't go to left diaphragm or the splenic hilar nodes or splenic nodes. So that is why you need not remove the 11P or 11D in D1 plus, but in D2 you remove 11P. Not 11D because the pathways are different. Similarly, pylorus prostrate gastrectomy is also designed. So is the proximal gastrectomy. Again, there is no D2 lymphadenectomy in proximal gastrectomy. So the lymph node clearance is not radical in proximal gastrectomy, and by and large, they don't do the proximal gastrectomy in Japan, and it is not recommended. Again, coming to non-standard surgeries, when do you remove splenic hilar lymph nodes? The main conditions are either it is involving gastric greater curvature of the stomach, and by default, it also goes to station 4SB. So if it is greater curvature involved and you find out enlarged 4SB node, or if the greater curvature involved alone, you have to go and clear the station 10. And please remember that for removal of station 10, you need not dissect, remove the spleen. Splenectomy need not be done. It can be avoided. And when it the other end of the stomach, when it is going to the 14V, the level 6, I think 14V has to be removed. That is along the supremesogenic vein, the gastropolyp pedicle. So D2 plus, when do you remove level 30 lymph nodes? When you have a tumor, gastric tumor infiltrating either to the pancreatic head or to infiltrate duodenum, station 3, which is retropancreatic, need to be removed. And when do you remove level 16? When you have isolated paratic node metastasis, even though it is considered metastatic, this is recommended according to the Japanese guidelines, and only after NAC. Coming to the lower esophagus, you need to remove the paraesophagus as well as periesophageal lymph nodes as well. Remaining things are pretty much same. Okay, if you look at the guidelines, I think most of the oncologists in India, the NCCN is followed like a Bible. But if you read the NCCN in reference to the extent of lymph node resection, it still says that D2 lymph node resection, node required procedure in the West. It's very, very, very pathetic, very backward step. And unfortunately, the ESMO is little more aggressive in advertising this in all specialized high volume centers with appropriate surgical expertise. I can still understand why you need so much surgical expertise in removing a D2 lymph nodes in Europe and US. Okay, now I think I come to the next part of the discussion, which is lab versus open surgery for gastric cancer. Is a lot of debate have happened and a lot of trials started. Initially, it is the early gastric cancer is accepted, especially when you have the D1 lymph node, lymphadenectomy, it was accepted. But the various trials, for example, Chinese has done class trial, the CLSS trial 1 and 2, then Koreans has done class trial 1 and 2. And essentially the class 1 trial in Korea was looking into the feasibility and advantage in the early gastric cancer in D1 resection, and it has been accepted. But for the advanced gastric cancer with a lot of gastric nodes and the D2 nodes, many surgeons in India and abroad are still very resistant in doing that lab resection. And I think that, even I have a fantastic surgeons, gastroenterologist surgeons in Kerala. None of them are advising the D2 lymphadenectomy or laparoscopic D2 lymphadenectomy in stomach cancer. And if you look into the surgical satisfaction by removing the entire package of tissue with birsectomy and clearance of lymph nodes and each artery being resected, skeletonized, many surgeons won't get the satisfaction of doing a lab resection, and still it is getting not getting accepted by worldwide. But there is the lot of evidence has come for supporting the lab resection is acceptable and early as well as advanced. The last one is the class 2 trial, which is completed in Korea. I don't think they have published it, but it is acceptable now. And the Chinese class 2 trial already accepted the advanced gastric cancer being managed by laparoscopy. And interestingly, there is a study which is published in Cochrane. It's a meta-analysis. And they have found out, even though the evidences they discussed was very low quality evidence, but even then there is no difference in short-term as well as long-term outcome in laparoscopy versus open. But again, I have visited many countries, including Japan, but I have seen many surgeons are still confident or comfortable in doing open surgery, and I leave it there. So coming to the birsectomy. Again, birsectomy is considered to be one of the sacrosanct step of gastrectomy. But if each component of gastrectomy, when they analyze separately, they found out that the birsectomy per se is not very useful or essential in survival. But omentectomy alone should be okay. But if you're open surgeon, you'll be more comfortable doing a birsectomy. Okay, so I think I have completed my slides. Anyway, I'll show a laparoscopic video where I did a surgery, and essentially this is a clearance of station 8, station 9 as well as station 11P. So my take on this issue is that, again, a lot of surgeons are very comfortable in open surgery, but the beauty of laparoscopy is that I didn't show, my picture didn't come, but you can have a fantastic dissection of the hiatus, the proximal stomach, entire lymph nodes in laparoscopy. And not only that, many times when you treat a locally advanced breast cancer, locally advanced stomach cancer, or non-early stomach cancer, after the patient comes back after neoadjuvant therapy, many times it may be inoperable. So, being known as a minimally invasive surgeon, whenever I did an open gastrectomy and went back to the patient and said it is inoperable, I faced a lot of criticism from the patients because they said, doctor, why don't you do a laparoscopy first? So in that context, I think I strongly recommend that you have to do a laparoscopy whenever you are comfortable with. And the dissection of the lymphatic stations 8A as well as 9 and 10 are fantastic in laparoscopy. And I don't think you should, even if you do this resection, you need to make a small incision for specimen retrieval. But if you feel that some areas are not well taken out, you can still complete the lymphadenectomy during the open phase of your surgery as well. So I'm showing the video of.
I am presenting a video of D2 lymphadenectomy in gastric cancer.
So this step is very important.
The tissue just above the pancreas is being dissected.
So usually camera port is placed in supra-umbilicus, 5 cm above the umbilicus, and patient is put in modified lithotomy and stand in between 2 working ports on either sides, and there are 2 retraction ports on the right side. The assistant, once they lift up the left gastric pedicle. By retracting stomach, and this gives a wonderful view of the left gastric artery. Then you can trace the hepatic artery proximally as well as splenic artery upwards. The instrument being used is ligature.
Lymphadenectomy. Now, the lymph nodes at the origin of the bifurcations and celiac area being dissected to the right side. And going towards the right side of the patient, you can see the hepatic artery going to the liver. The lymph nodes, the junction of the celiac axis and hepatic artery being dissected. And as the dissection reaches up along the left gastric, you can see the crust. So in fact, the distance from crust to the axis is much less. Now the lymph nodes are being traced towards the hepatic artery, and too much retraction will sometimes bring the portal vein into the dissected area, which is unnecessary. In fact, we need to clear only station 8A lymph nodes, that is, which is along the hepatic artery. Attempting to clear more lymph nodes behind may result in injury of the portal vein, especially in laparoscopy, because we are having only 2-dimensional view. So the remaining 8A station lymph nodes are being dissected. In fact, the dissection is being done over a triangle, which is formed by the crest, hepatic artery, and left gastric artery. Once the lymph nodes are dissected from the crest, now it is being dissected from the hepatic artery. The issue of dissecting lymph nodes in D2, especially along hepatic artery and splenic artery, etc., are the risk of bleeding from minute branches of the portal vein. And that's why we have to use energy source like ligature to dissect it away. Otherwise, the bleeding can be a little troublesome and our field will get compromised. I feel laparoscopy is very helpful in having a very close vision of the area, and the visual angle of camera will help you positioning yourself at appropriate places so that surgery is done with more ease than open surgery. Now, as we approach the portal vein, I stopped. I'm not going any more behind, and I'm stopping my lymph node removal at station 8A. In fact, on average, even though we remove so many lymph nodes in D2 gastrectomy, hardly 4 or 5 are positive. So we should be very careful in not removing extra stations and causing injury. So I am stopping short of reaching the portal vein and finishing off the lymph node removal there. Because of the lack of maneuverability of laparoscopic instruments, going behind is a little tricky because once you have bleeding, it is a bit difficult to control. Now I have started dissecting left gastric as well as celiac axis, which also the area of the splenic artery from the left side. The delineation between the pancreas and the lymph nodes are often difficult, but for an experienced gastrosurgeon, the fat can easily be differentiated. Fat and lymph nodes can easily be differentiated from the pancreas. Now, I'm going to the crus area to little more dissect the left gastric towards the upper part, as well as to dissect out the crus. Dissecting out the crus is so very easiest maneuver. Now the left gastric vein and artery are being clipped. Remember, these arteries should be clipped only after proper dissection of the celiac axis, the hepatic artery, and origin of the left gastric artery. Otherwise, dissection will be extremely difficult, especially with the plastic clips in place. This is hemolog clips. Now I am discontinuing my dissection along the superior border of the pancreas to expose the splenic artery. Splenic artery will be dissected only up to the origin of the posterior gastric artery. Especially the tumor is not on the greater curve or station 4 lymph nodes are involved. Once these are involved, there is necessity of going a little further and even dissecting the splenic hilar lymph nodes, which is station 10. Now I am reaching the posterior gastric artery, which is given from the splenic artery. posterior gastric artery is clipped and cut. The size of the stomach and the lay of the stomach and width of the stomach is creating a lot of issues, which has to be circumvented by proper assistance and retraction. Now I am concentrating and moving towards the greater curvature area. The attachment of omentum to abdominal wall is being released. After that, it will be dissected away from the transverse colon and splenic flexure without causing injury to these structures. And the surgeon often has to go medially and laterally and continue the dissection of the cardia. The advantage of laparoscopy is that after this dissection, the scope can be entered into the esophageal hiatus, and mediastinal dissection can be done even up to carina. You are seeing the left lobe of liver anteriorly, which shouldn't be retracted in laparoscopy. In open surgery, division of ligaments and retraction of left lobe is an important part of the surgery. Now I am moving on to the short gastric area to dissect the short gastric vessels. Shortly, we will see the spleen. This bunch of tissue contains the short gastric. Here, extra precautions will be taken not to go near the splenic artery or splenic hilum and injure it. Now I am reaching towards the last part of my dissection where the spleen is seen and the short gastric with few remaining short gastrics and stomachs are dissected medially. And this last bit of division of tissue completes my abdominal mobilization. This completes my mobilization laparoscopically. A small incision will be placed in midline, and resection and anastomosis will be completed.
Thank you.
I think that was a fantastic lecture with the details about lymphadenectomy and a great video laparoscopic D2 dissection. I would like to invite some comments from Professor Subramanian Rao.
Can you permit me to use my video? They're not allowing me to use my video.
Yes, Jagdeep, please.
Because the host has stopped.
Enable the video.
Rudra.
Yeah.
Rudra, I understand I'm not the best looking, but that doesn't mean.
No. I think
doesn't mean people not see me.
No, I was also not able to open my video. Please, Jagdeep.
So we both are not. It's all right. As long as you are able to listen to me, I think it was a wonderful presentation. each time Chandramohan talks, he talks much more than he himself would have talked. And stomach cancer is something that has always been very close to his heart. So I think we have a very heterogeneous group of friends who have been listening to him. We need to ask him. Actually, he has covered everything that I would have wanted to listen regarding the basic surgical aspects. He did not get too much into systemic therapy, perioperative, preoperative, and things like that, because the group is predominantly general surgery. So we'll stay that way during the dissection, and we'll ask in the initial part. There are quite a few questions that the attendees and the panelists have actually typed in the chat box. We'll ask that too. But a few things that we would want to know from him as far as his own practice is concerned. He has shown what the world thinks, what East thinks, and what West can manage to do. In a general surgery group, we need to test how often do you operate upfront, Chandramohan? In an Indian context, we are not talking about T1A and things like that very often. So in an Indian context, how often do you operate upfront at the regional cancer center?
Thank you for the question. I think it's a very important question. And my answer may not be the answer anyone other person is giving. But here in my hospital, we don't get to see T1A cancers. And other than emergencies, other than patient present with obstruction, goo, or bleeding, they straight away go for surgery. All other patients are going for a new urgent protocol.
Subbu sir, you can open your camera now.
In this context, I'd also like to say, yes, sir.
Now, do you have situations like obstruction? One of the chat box. What do you do in a gastric outlet obstruction T3N plus N0 rather?
The answer, sir. Straight away surgery.
Gastric outlet obstruction patient, would you not operate despite the fact that you would want to give chemotherapy?
No, I will operate, and I am not a die-hard ardent fan of chemotherapy as well, because there is a fantastic study from Adyar where Ramakrishnan looked into the survival, and he found out that even patient T3, T4, N plus patients who received upfront surgery say having equal survival.
Absolutely. What about the proximal margin is something that is being discussed with some stress. Even in the guidelines, they say now proximal margin, if it is possible, has to be controlled by section, because resected specimen showing margin positivity as far as proximal margin is concerned is significant. So would you advocate that? Proximal margin is a serious affair. So you talked about it, but frozen section as a routine, NCC and that, the guidelines also which say that. So would you do control the proximal margin in all gastrectomies or selectively?
My answer is the proximal margin is very, very important, especially in patients we try to do avoid a thoracotomy or thoracic procedure, especially O-junction tumors. The recurrence was very high. The positive margin was very high. But I am not very even happy with the frozen section also. Frozen section will say whether margin is negative or positive. But I think the closed margin is as bad as the positive margin. So you have to, the dictum, no, I specifically asked these questions to many Japanese surgeons. And the answer they said was, if it is a poorly differentiated carcinoma, not even frozen negativity is okay. You have to have a 5 centimeter margin proximally. So otherwise, it is going to have bad results.
Keeping G junction aside, gastric cancer, say, would you advocate? Would you want to control proximal margin?
Yes, sir. Gastric cancer, the discussion about the distal gastrectomy is only for distal tumors. Anything in the mid body, if you distal tumor by default, if you do a proper gastrectomy, and the most important thing in rather than luminal margin, the most important thing is having a lymph node clearance. Even if you are doing a proximal distal gastrectomy, you have to clearly dissect out the entire hiatus. Up to the hiatus, remove all lymph nodes, and then only to the tissue, the lumen has to be, distal to lesser curve has to be preserved. So 2/3 of stomach has to be removed. It's very, very important.
Your margin changes with histology? Your margin changes with histology and this types of cancer?
Okay, but if you are getting 5 centimeter margin, it's okay. But if you are compromising on that, it changes with histology. For example, if you have a, you can't give a 5 centimeter margin. If it is well differentiated, intestinal, 2 or 3 is okay. But it's diffuse, it is poorly differentiated, I think insist on 5 centimeter. At times it changes.
But it is very difficult to know the
Pancreas resection.
histopathology on table unless you send for frozen section.
Previous biopsy.
Yeah.
It's by radiology, it's by clinical impression, whether it is laparoscopy or laparotomy, that you can have a reasonable conclusion. And the preoperative biopsy also can give you a guideline, although it may not be always perfect. There are lead points to understand that whether it is diffuse or otherwise. Age of the patient, gender of the patient also contribute. And pancreas resection, I would have always accepted. It's a very, very individual opinion. Splenectomy, how does it actually increase mortality? Splenectomy alone, how does it increase mortality? In cytoreductions that we are doing, we do so many splenectomies, we rarely have.
Yeah, I think that is one bias.
Data, can you dissect the data for us? Is there data talks pancreatectomy and splenectomy separately?
Sir, not only splenectomy, even with pancreatectomy, our patients are not faring bad. But if you look at the Western country, physiology is different. The splenectomy means patient have a lot of issues, and they don't tolerate splenectomy as we tolerate. So that's why you have the very bad results coming from the D1, D2 dissection trials. But we right and left, we are doing splenectomies, and our patients are okay with that.
If you have a chance, if you're doing neoadjuvant therapy for a greater curvature lesion, would you give vaccine before you are planned splenectomy, like you do in cytoreductions?
Yes, sir, it should be. And my
would you give the?
Yeah, so I don't try. I mean, plan for a splenectomy. I try to do a hilar dissection without a splenectomy. But of course, a vaccine has to be given. A splenectomy need to be done if needed.
If you're giving neoadjuvant, probably it's a good strategy to plan vaccination for surgery after neoadjuvant therapy. What is your preference of reconstruction?
It's Roux-en-Y, because the lot of quality of life studies have shown that when you don't do Roux-en-Y, and especially in the proximal gastrectomy, things are fantastically bad because it creates a lot of anastomotic stricture and the reflexes. But Roux-en-Y is okay, but there are many people who are advising the pouch also, but we don't do a pouch.
Would you ever do a proximal gastrectomy?
Yeah, I think I'm not happy with that. It can be done in patient who is compromised. The only issue is that we have a patient who is having little compromise. It's no man's land. If you need to remove a little of esophagus and you have to do reconstruction, and the stomach also has to be gone. And for a patient with a morbidity, the easiest thing is to end up with a proximal gastrectomy rather than doing a proper esophagectomy and bringing in.
So you never do a proximal gastrectomy for a cancer. You would probably do it for a stromal tumor and benign tumors.
Yeah, like this.
That is the message.
Yeah.
Sorry, if it is a very compromised patient.
Now, Jagannath Dixit actually asked, what is the role of a double track reconstruction?
So double track has been shown in the
and double tracking.
class 5 trial. It is shown to be superior to the proximal gastrectomy. So I think you should use, but we are not practicing it. So there are a lot of questions in. Can I read?
Yeah. Lot of questions.
Yeah,
so before
good.
Before that, I will take just a few moments to announce NatCon ISO. I think Jagpreet, you can put the video. So I welcome on behalf of ISO to NatCon 2021 this year, being held virtually, being organized by Delhi NCR Onco Forum. And we have a huge scientific program with 5 halls and 2 weekends. We are going to pack it with academics, and it is just like in the format is that 5 halls, site specific, and morning and evening 2 sessions. Morning 7:30 to 11:30, and evening is 4 to 8. 4 days. So it is going to be packed with a lot of programs with a virtual halls, 5 halls. And there is a specific innovation hall E, where a lot of new things will be discussed, like AI in oncology, research methodology. And we have a complete international speakers research program. And especially we are going full program on surgical pathology from OR to the lab. So I think we have a lot of new things coming up this NatCon. And we have introduced one new case-based discussion called as Oncologics, how to do surgical oncology decision-making in cases. So we invite the participants from institutes in groups. 4 persons can participate. Surgeons, radiation, multimodality treatment will be discussed. So this year, the NatCon will be completely different. And although it is virtual, I think it is more academic than a physical meeting. So we welcome all, and we expect a lot of abstracts, videos, oral presentations for NatCon. And we have put a lot of effort in making this as a big virtual academic mega event. Thank you very much. I think Subbu sir and myself will now go to the questions chart, because I think there are a lot of questions lined up. We can start from the top.
Rudra?
Yeah.
Yes, Rudra. Rudra, go ahead.
Also.
Good. Rudra?
Yeah.
Before we go to the question, let us. Dr. Rashesh Solanki also will take his comments also.
Yeah. Please.
Yeah. Dr. Rashesh bhai?
Where is Rashesh? Wanted to see Rashesh.
Yes, sir. It's a pleasure to be amongst you all. Yeah. Thank you, Bhavana, for inviting me, and it was indeed. I enjoyed the talk, especially the video part. Now as we become senior, we tend to be more focused on the technique somehow. But Dr. Nirmohan, it was interesting that you mentioned that there was a study from Ariad which looked at neoadjuvant versus upfront surgery in locally advanced or CT3 N plus tumors, or was it CT2 N plus tumors, T2 beyond? And we have been there are a lot of voices that raise the concern that maybe the Western guidelines are not applicable to our scenario, our setting. Would you discuss that study in a bit detail, sir? The salient point.
I don't remember that, but I have personal chat with Ramakrishnan, and he only mentioned about the particular study. Basically, in every institute, lot of patients are getting managed without upfront surgery, and when they looked into the long-term outcome, they found it's at par. So many times the so-called sacrosanct principles of oncology, and that may not be holding good in our day-to-day practice.
Thank you, sir.
Thank you. Okay. Now, there are quite a few questions, Chandramohan.
Yes. Shall I read it? Or?
Arvind Guru asks you, in a case of positive post NACT, what is the management of positive distal margin? Focal positive versus frank positive. So basically, positive margin, if it is focal positive, what would you do? Frank positive, what would you do?
See, first of all, I have to look into the other aspect of the disease. So margin means only one point where it is positive. How the disease otherwise behaving? Is it a widespread disease with a 40 out of 40 nodes positive, and with a very diffuse type of cancer with a aggressive looking biology? Then I don't think addressing this positive margin alone is going to cure the patient. But if you have a positive margin only because of surgical results operated elsewhere with a frank positive margin, in a selected number of patients, you can consider redoing it if it is possible and feasible. But otherwise, usually the first surgery itself is the best surgery for the patient. So even if you do a positive margin revision, I don't think the results are as good as a primary surgery. So in my opinion, the re-laparotomy for a patient having positive margin should be very, very selected and limited.
No,
So
especially the distal. Yeah. Good.
Next question is extent of lymphadenectomy in gastric lymphoma.
I don't think lymphadenectomy is needed in gastric lymphoma.
Correct.
No,
Sir, want to say
regarding the
something?
distal margin, I think Chandramohan, no, Arvind wants to know whether you will consider radiation therapy apart from chemotherapy.
Sure. So
I think that's what he wanted. Okay.
So Dr. Jagannath asks, molecular staging has more to play than histology alone.
Yeah, it's going. Maybe another 5 years, we are going to manage based on molecular staging. It's getting very, very popular and very, very fast advancing area of research.
There are two very basic questions. One is, if you find there is no peritoneal disease and cytology alone is positive, then what will you do on table? The other one is, if the patient presents with a gastric outlet obstruction, then what will be your approach?
Yeah, gastric obstruction, straight away surgery. No question about that. And once you have the gastric lavage positive, it's confused. Either you can, if you have the hypec surgeons will do hypec, otherwise patient will be sent for a chemotherapy and reevaluation later on. And there is some kind of surgeons who just send for palliation. It's a trans-global divide. It's a transatlantic divide. I don't have a solution for that.
So another question was, after you do the lymphadenectomy, do you label them or you send an mass to the pathology?
Yeah, I think the labeling is fantastic, and we have done it. A couple of our students have done as a thesis protocol, and it's simply the dissection in a wet specimen alone will increase your lymphatic yield to almost double. And if possible, please do that. I recommend that.
So surgeon does a better crossing than the pathologist. That's what you mean.
Yeah, definitely. Because I think the lymph node stations, the pathologist might be missing, and we might do a proper station-wise mapping actually. That is very important.
Yeah, then only we know. No, we have, if you analyze our 2,000 cases, we know which went where, which node was positive. Otherwise, we don't know. The pathologists have no ways and means to find out which station is positive.
So another question is, do you use 3D lab or robotic in gastrectomy?
I think 3D lab is excellent. I don't use, but it is excellent. I think I don't have a luxury of it.
And robotic?
Robotic, I don't have experience. Virudra, you can tell any advantage of robotic or
especially in the upper abdomen, I haven't used. I have used mostly for esophagus and rectum. I think there are few people who are well accustomed, even use robot for D2 gastrectomy.
Yeah, I think the issue with the laparoscopy is you have to have a lot of maneuver. Don't have maneuverability at the end. If you can have a maneuverability at the end with the
especially for as you told, you stayed at the 8A. You did not attempt the 8B and 8P, which can be done with robotic when you can go behind the portal vein. Actually.
Excellent, excellent.
Why do you see more younger patients in India? Again, Jagannath only asked this.
I think, sir, any cancer, more youngsters, we have seen more youngsters. Whenever I went to any of the overseas training few years back, most of the cancer wards are full of old people. Only in India, we see young patients everywhere. I don't know the reason, but that is some reality.
Part of the reason could be that we have a young population, is it not? Age-adjusted rates, there will not be such a wide variation. What is, you have a young population, so when you have patients, about 130 per 100,000, a significant number of them will be that reason, but there are other reasons also. Maybe our molecular subtype may be different.
Also, the population pyramid.
Molecular classification, molecular subtype also may be different. That's what is said about survivals in Japan. In similar stages, also molecular type may be a reason. Follow-up after total gastrectomy, is it any different, Chandramohan? Because surgeons keep seeing these patients for follow-up.
Yeah, I think one thing we have to be really careful is the nutritional issues, especially vitamin B12 deficiency.
Yeah, really, yes, I think that's what they wanted, yes.
Supplement either orally or injection.
Yeah, definitely cancer nutrition is a big problem, whether it is esophagus or stomach. So I think we should all be, we are all using some kind of partial parenteral nutrition, whether post-op or pre-op to make our patients fit. But definitely nutrition is a concern. That is why this time in NatCon, we have a special session on cancer and nutrition.
Rudra is marketing NatCon here and anywhere. So, total gastrectomy, you'll have to be worried about iron and B12 also, isn't it?
Yeah, correct.
Status, yes. What else?
I think,
Bhavana, silent.
Dr. Ratna is there. I think she wants to ask some questions. She was my earlier colleague.
In the meantime, do readily do 4B, Chandramohan. If 6 is positive, because we keep seeing lots of 6 positives, do 14B.
Sir, Japanese recommendation is ideal to do, sir.
No, if the 6 node is positive on frozen, you find it little bulky or something. No, routinely we don't do. But if we find a big node at station 6, then usually we send for frozen. If it is positive, definitely
we find it very often.
And if you find it, then ideally you should do 14V, because it is just going to the supraimagentric area, and you can go for it. But definitely it is little bloody actually, but still you can manage.
That doesn't matter. That doesn't matter.
There's a question, what is the role of palliative resection even in inoperable locally advanced cases?
Yes,
so,
yes.
I think the answer is it's easily resectable because resection is good, because it will avoid bleeding. If the patient has bleeding, it will stop. And a gastric resection and removal of the tumor is, I don't know whether it's a survival advantage, but if it is very easy, that will have some advantage on the psychological aspect, mindset of the patient. And the easy resection is not going to cause much issues. Once you have tumor, later on issues like tumor bleeding can happen. So I support resecting a easily resectable tumor even if it is metastatic. another question is solitary paralytic node, CT on PET. How should we approach? So I think slowly we are evolving, even though the guidelines are saying paralytic nodes or metastatic, shouldn't touch it. But of course, in selected patients, removal of extra nodal stations have increased survival. And if it is only one paralytic node sitting, I think maybe your MDT can decide on it, and after trial of chemotherapy, you can take it out.
Yeah, usually, actually,
Niket,
whenever you find 9 is positive, then you will always find the 16A positive. So, although 16A is a paraotic, but if 9 is positive, then 9 and 16 are very close to each other. So, we find always 16 is positive. So, in those cases, it is better to dissect the 16 and map it. It will both help in knowing its positivity and also making it mapping wise, that if it is metastatic, then the prognosis is poor. So both ways, 16 will help. If 9 is there, then you should go for 16. They are very close.
So what will
Devendra Parikh wants to know experience of stenting for gastric outlet obstruction, treatable low-cost cancer by definitive treatment.
sorry, it
Role
depends
of
upon-
stenting as a bridge, as a bridge to
somebody else
resection.
also asked the same stenting.
stenting, I think just it is never equivalent to the open palliation. But if you do it for a temporary bridging, I don't know. I don't have experience, or you can comment, Subbu sir.
I think very few cases we have
We-
stented and
we have-
given neoadjuvant chemotherapy, but usually they later on become metastatic. They never turned up for surgery.
So how long we have to wait? Yes, sir.
We have sent a few patients, but I have never operated on a stented patient. Correct.
Yeah, correct.
We never operated on a stented
I have
patient.
never operated.
And how long we have to wait to go for gastrectomy of carcinoma stomach after NACT? 1 month.
Do you want to mean the duration?
Yeah, I said
4 to 6 weeks.
1 month.
So how often,
Neoadjuvant
Subbu sir,
chemotherapy.
how often do you take HIPEC as a in stomach actually?
Never. Not yet. I did not find a patient as it. I never found a patient who has less than 5 PCI and a resectable stomach cancer in my life. It must be a very small group of patients. It has to be low PCI, around 5 PCI, and resectable. These two things don't go together in our patients. I've never seen one patient who would have deserved HIPEC.
Because most of
To
them
come up with this
are
molecular
above,
classification.
above 8 in scoring, and most of them are
Correct.
16 or 18. So we never get that chance actually.
Correct. True. No, only hope for HIPEC is prophylactic HIPEC in molecular classification, MSS, EMT. That's where the peritoneal metastases seem to be very common, which means the peritoneum is already seeded with deposits, but it is not showing up. So they become, you would do a prophylactic HIPEC, because most of the relapses later on are peritoneal. You preemptively do HIPEC. So I think it will take some time before we reach that stage. There are some hints
This
and
is a
leads that
good subset to do HIPEC.
Correct.
So what is your opinion?
I think we are.
What is your opinion? Better staging.
Pardon?
What is your opinion? Is better staging by ANM, USCC, or Japanese nodal stations?
No, Japanese, yes. Japanese.
We always follow Japanese
Let us give
mode of staging. Yeah.
Dr. Arun is asking where stomal cancers, any difference in approach? Stomal, I think maybe, gastrogenostomy cancers,
Yeah,
any difference?
correct. Stromal is on the jejunal
They're
side.
slowly decreasing in number. They're slowly decreasing in number because benign peptic ulcers being treated by stoma has become very rare.
Because of
They are
proton
not
pump
often
inhibitor,
operable.
PPIs. Lot of PPIs.
Yes.
So Dr. Rohit asked, is there a role for mesogastric resection like mesopancreatic resection TME or carcinoma of the rectum? I have not heard of it, mesogastric resection.
Yeah, mesoesophagus is there, mesopancreas is there, mesocolon is there, mesorectum is there. But if you mean that the attachment between the pancreas and the posterior surface of the stomach, then it can be a stomach. But usually they are very thin layer of peritoneum.
It's other name for bursectomy.
Yeah, it is called as bursectomy rather than mesogastric. And one very important
It's
thing.
other name of.
Yeah, now it is not full bursectomy as Chandramohan told. Even partial bursectomy is acceptable because the laparoscopic surgeons have bulldozed the treatment. So I think partial bursectomy is also acceptable.
So Dr. Jagannath Dixit is asking MSI, PD-L1 tumor mutation burden based on any safe for immunotherapy treatment. I think last ASCO there was a lot of presentations about immunotherapy being used for OG junction also. I'm sure it is going to come very soon.
Yeah, for pembrolizumab is PD-1 antibody inhibitor, and that has been actually approved in 2017 for metastatic and unresectable MSIH or
even as an
PD-L1.
adjuvant role it is coming.
Yeah,
Adjuvant role it is coming very fast.
adjuvant role will be coming, but it was already granted in 2017 for unresectable tumors.
Or metastatic disease.
Yeah, it is metastatic unresectable tumors only.
But another role is HER2 receptor actually. HER2 is very important in G junction and in proximal stomach tumors, and they have shown very good results with Herceptin actually.
Yeah, that is a TOGA trial actually, and it is good for gastroesophageal junction adenocarcinoma and advanced gastric.
Any comments, Subbu sir? Herceptin.
I don't know. It's fine. Not otherwise. It's not as yet. As an adjuvant, you mean?
Adjuvant.
As an adjuvant, I don't. For metastatic, it is very useful.
So there are two trials for Herceptin actually.
I think we should wait.
Hello.
Yeah, please.
Yeah, one is TOGA trial, which is actually for the locally advanced gastroesophageal junction adenocarcinomas and gastric carcinomas, and it is also for the locally advanced recurrent and metastatic disease. And another is a phase 2 trial, that is Herxtro trial, but that results are not released actually. It is with the Herceptin and capecitabine and oxaliplatin. That is also for the advanced gastric and gastroesophageal junction adenocarcinomas. So Herceptin might come in picture maybe after some time for maybe for adjuvant also.
Correct. We'll have to wait for some time. Yeah. I think it's 10 o'clock.
Yeah, so we will wind up. I think
more than
Bhavana, thank you very much for organizing, and Chandramohan and Subbu sir for thank you sparing the time, and it was wonderful. We had 187 logins at the maximum point. 210 had registered, but I think 187 was highest point. And still we have 100 people at the end of the meeting. So it was very nice. Everybody listened to Dr. Chandramohan and Subbu sir. Bhavana.
Thank you, Rudra Bhai. Thank you, Chandramohan sir, for summarizing entire CA esophagus in a very nutshell. We reached up to 190 participants at the maximum point at one point. And thank you, Dr. Subramaniam sir, Dr. Rashesh Solanki. We missed Dr. Nita Ninama, Nita Shah, and thank you everyone. There are a lot of senior consultants were there also as a participant. So thank you everyone. Thank you, sir.
Yeah. Thank you.
Thank you, Bhavana, Rudra,
Thank you.
Rashesh,
Yeah.
Naina.
Thank you, the
Chandramohan,
event
great job.
managers, for doing nice,
I had a wonderful time. Thank you very much.
uninterrupted technical.
Correct. Correct.
Thank you very much.
Best of luck for NatCon.
Thank you. We'll
Thank
see
you, sir. Thank you.